Hypothalamo hypophysis diseases. One of the most syndrome of hypothalamo hypophysis diseases is hyperprolactinemia. Hyperprolactinemia is a syndrome with prolactin hormone hyperproduction. Etiological factors is different. Pituitary adenoma, prolactinoma, the most often. Primary hypothyroidism, very important and very seldom diagnosed one we cross Hennes syndrome. Hypertrophy of prolactotroph cells and medical drugs, domperidone, neuroleptics, Betamax, or other drugs can lead to hyperprolactinemia. Pathogenesis of hyperprolactinemia, that is the diagnostic of two types of prolactin and hyperprolactinemia with micromolecular biologically active prolactin hormone which attached with cells targets, and macromolecular prolactin biologically inactive, but it can give hyperprolactinemia too. Macromolecular prolactin is a compound of macroprolactin and antibody. That is only one point of view. High level of microprolactin leads to decreasing of LH and FSH hormones, which leads to, in a man, decreasing of testosterone level and problem with sexual life, and in a woman, decreasing of estrogens and progesterone. The main complaints of hyperprolactinemia in a woman: infertility, dysmenorrhea, galactorrhea, and the first doctor who met the patient with such a complaints is gynecologist, obstetric and gynecologist doctor. In men, the first complaints for impotence, infertility, gynecomastia, and the doctors, urologist, can meet the patient first of all with such complaints. But clinical symptoms of hyperprolactinemia includes the excess of prolactin production with breast glands, galactorrhea, mama glands enlargement in men, dysmenorrhea and amenorrhea in women, and infertility. Symptoms of mama glands enlargement can be in men, and sexual disorders, hypogonadism, impotence, and infertility in a male in adolescent and adult age of men. Clinical symptoms of hyperprolactinemia accommodated with rising of appetite and weight gain, headache, incurable with aspirin and paracetamol, vision disorders, reducing of side vision, and hirsutism and hypertrichosis are also possible. Algorithm of diagnostic of hyperprolactinemia. First of all, the complaints and typical clinical symptoms requires the investigation of blood serum prolactin, especially micromolecular or biologically active fraction and macromolecular. Micromolecular prolactin should be more than 60% normally. Thyroid hormones investigation to find out primary hypothyroidism. First of all, the patient with hyperprolactinemia should be investigated with TSH hormone, the test of the first line to exclude the primary hypothyroidism. Visualization of hypothalamo hypophysis zone with MRI is contrasting. Prolactinomes can be very large, from 1 to 4 centimeters, and that is like a macroadenoma, because microadenoma is less than 1 centimeter in diameter. Investigation of blood serum sexual hormones level if necessary. Algorithm of diagnostics of hyperprolactinemia. First of all, investigations of blood serum sexual hormones level when we diagnosed hyperprolactinemia. Testosterone in a male, estradiol progesterone in female, and FSH and LH hormone. Ophthalmological observation. Eye bottom, fields of vision to find out by the temporal hemianopsia. We can use digital devices or circumference with a red, green, and white mark, because the first signs of bitemporal hemianopsia can be found out with a red mark, then green mark, and later in a white mark. The enclosing of fields of vision is very important to prepare the plan of treatment. Principles of treatment of hyperprolactinemia. Therapeutical treatment includes cabergoline drugs as selective agonists of each one dopamine receptors. That is very effective for treatment of micromolecular hyperprolactinemia. Dopamine is brake mediator, and it blocks synthesis and secretion of prolactin and stimulating hormones. Selective agonist of H1 dopamine receptors, brake effect of biologically active prolactin only. Monthly control of prolactin level with titration of dose. The first dose of cabergoline is half of milligram per week, and then after 1 month checking of prolactin hormone level, we can exceed the dose twice. For example, the patient can take half of milligram twice per week. Then titration of dose leads to normal level of prolactin, and we can use the maximum dose from 6 to 8 milligrams. But majority of the patients use half of milligram in a day or every day. It depends from the first prolactin hormone level. Principles of treatment of hyperprolactinemia includes the MRI control 1 time per 6 months to control the adenoma size. Treatment with cabergoline drugs leads to reducing of adenoma size in the case of hypermicroprolactinemia. The huge adenoma can push on the crossing of nervus ophthalmicus according to investigations of fields of vision. That's why the obligate indication. That's why it is obligate indications for surgery of adenoma, because that is very dangerous for blinding. 1 week Ross-Ennis syndrome. That is the syndrome occurs due to primary hypothyroidism. I can explain it. Low level of free T4 accommodated with increasing of thyroleberine. Thyroleberine stimulation leads to increasing of both hormones, TSH, thyroid-stimulated hormone, and prolactin. That's why hyperprolactinemia with increased TSH level and decreased free T4 level has to be treated with levothyroxine. After administration of levothyroxine, we should approach the patient to compensation and to find out normal level of free T4 and TSH level. and we expect normal level of prolactin. When the prolactin level uh, is increased after compensation of hypothyroidism, we should add the treatment of hyperprolactinemia with cabergoline, first of all, to confirm microprolactin level of hyperprolactinemia.